Let's turn to the financing of oral health care. Access to care makes a difference. A complex set of factors underlies access to care and includes the need to have resources to pay and reimburse for care. Among other factors, the availability of insurance increases access to care. In this section, we will examine how oral health care is financed in the United States. Overall, dental expenditures are not a significant driver of medical care inflation. In fact, dental as a share of the national health dollar declined between 2007 and 2012, probably more due to an increase in medical care costs than to a decrease in dental costs. This probably helps to maintain the status of dental services as a less necessary service that does not need to be included in larger healthcare financing discussions. Private insurance programs meet the costs of providing dental care by collecting premiums. This is really a dental prepayment plan rather than insurance. All plans have a maximum cap of yearly expenditures, usually set between $1,500 and $2,500. This is different from standard medical health insurance, which assumes much more financial risk for catastrophic events or prolonged care needs. In some sense, dental insurance is a misnomer. It is a prepaid card, and not all patients use its yearly benefit amount, while others exceed it and face out-of-pocket costs. Most individuals obtain dental insurance through their employers. Dental insurance has several methods of determining provider reimbursements. Most are very much based on a fee-for-service and the concept of piecework reimbursement. The UCR, which was abandoned by Medicare and physicians more than 20 years ago, is commonly used for dental plans. It consists of three components: the usual fee that is most often charged by the provider, the customary fee, which is a range charged by similar providers in a specific geographic area, and the reasonable, fees charged by a dentist for a specific dental procedure that has been modified by complications or unusual circumstances. Dental plans can also elect to use a table of allowances that does not necessarily represent the dentist's full fee, or fee schedules and discounted fees that dentists agree to accept as payment in full. Capitation programs have not gained traction in dentistry, except for some closed panel programs that service trade union members. This system features a fixed payment to a dentist based on the number of patients assigned to the dentist for treatment. Interestingly, this system is being viewed as a basis for boutique practices on one hand, and as a way to overhaul dental care away from fee-for-service to overall patient wellness. Public financing of oral health care is dominated by state Medicaid plans. Adult benefits vary greatly from state to state. They are nearly non-existent in some states, while others have a long list of benefits. However, benefits for children under age 21 are a federal mandate as part of early and periodic screening, diagnostic, and treatment services. Children who are not eligible for Medicaid and cannot afford private insurance can now be covered by the Children's Health Insurance Program. More on that later. Medicare pays only for dental services that are an integral part of medically necessary procedure. It would require an act of Congress to bring dental benefits into Medicare. Dental Medicaid benefits fluctuate with the economic realities of states and their inhabitants, both the providers and the patients. Overall, spending grew at an annual rate of 11.2% between 1975 and 2002. 40% of that was due to an increase in recipients, while 60% was due to increases in treatment and administrative costs. Economic downturns paradoxically raise Medicaid enrollments while decreasing state-specific benefits. Medicare excluded dentistry in 1965 with approval of organized dentistry. Those interested in oral health care policy are looking ahead to the growing number of aging baby boomers retiring with diminished or no private insurance coverage and no public coverage for their oral health needs. This is proving to be a rude awakening to older Americans who have maintained more of their own teeth than any cohort before them and who have been accustomed to regular dental care funded by employer-based dental plans. The Affordable Care Act does not offer any solutions to this older population. Dental care for adults is not one of the essential health benefits that plans are required to offer. Pediatric oral health care, however, must be offered in the 10-category Essential Health Benefits package for those under age 19. Again, this is a rude awakening for many adults seeking dental care assistance. One bright spot in the dental care financing landscape was the Children's Health Insurance Plan Reauthorization Act of 2009. This elevated dental services for children who fall into the area between Medicaid and private coverage to required service in CHIP plans. Yes, financing affects utilization of dental care services, and it follows that it affects access. This is clearly shown in this graph. From 2000 to 2010, dental care utilization among low-income children increased in 47 states as benefits to children increased. However, for low-income adults, utilization declined or remained flat in almost every state, reflecting the funding of dental procedures. Reductions in adult dental benefits in Medicaid programs in most states are a key factor explaining the decline in utilization among low-income adults.